Welcome to section 4 of neuropathology. In this section, we'll be discussing demyelinating disorders. Let's get started. Here's our overview slide. Let's begin by discussing some basic principles regarding myelin. Myelin insulates axons and increases conduction velocity. Oligodendrocytes synthesize myelin in the central nervous system, while Schwann cells synthesize myelin in the peripheral nervous system. Here's an image that depicts this idea. Notice the oligodendrocytes, which are responsible for producing myelin in the CNS, whereas in the PNS, there are Schwann cells. All right, with this in mind, let's discuss each disorder, beginning with multiple sclerosis. Multiple sclerosis is an autoimmune disorder that leads to demyelination of the central nervous system neurons. It's caused by T-cell mediated destruction of oligodendrocytes. There's an increased incidence in women between the ages of 20 and 30. There's also an increased incidence in warmer climates. And finally, it's also associated with HLA-DR2. A very important feature of this disorder is that the symptoms are relapsing and remitting. Patients may present with painful unilateral vision loss, known as optic neuritis. Internuclear ophthalmoplegia is due to damage to the medial longitudinal fasciculus. We discussed this in more detail in our neurology video on ophthalmology. Bladder and bowel incontinence is a result of autonomic dysfunction. Spasticity symptoms are due to demyelination in the cerebellum, and hemiparesis symptoms are a result of spinal cord involvement. Scanning speech refers to a disorder in which spoken words are broken up into separate syllables. So there's often a noticeable pause between two syllables. So patients have abnormally long pauses in between words and may even have slurred speech. All right, now let's discuss findings and treatment. In patients with multiple sclerosis, an MRI will show periventricular plaques, which are areas of demyelination. A lumbar puncture will show increased IgG, oligoclonal bands, myelin basic protein, and lymphocytes. Treatment can be broken down into two categories, acute and chronic. Acute treatment requires IV steroids, and chronic treatment includes interferon beta. Here's an image of an MRI showing periventricular plaques in a patient with multiple sclerosis. We can see the plaques indicated by the red arrows. Again, these are areas of demyelinated oligodendrocytes, as well as reactive gliosis. All right, now that we've covered some of the information, let's review with a question. A 29-year-old female with no past medical history presents to the physician with sudden painful vision loss. The patient states she had an episode of similar vision loss 9 months ago. The patient lives in Florida. What will most likely be seen on MRI in this patient? All right, this patient is suffering from multiple sclerosis. Sudden painful vision loss, also known as optic neuritis, is a classic symptom in patients with multiple sclerosis. Incidences of multiple sclerosis are increased in women between ages 20 and 30, and there's also an increased incidence in warm climates, such as Florida. So the MRI will show periventricular plaques. All right, now let's discuss Guillain-Barré syndrome. This is a group of disorders resulting in progressive muscle weakness. The most common form is acute inflammatory demyelinating polyradiculoneuropathy, or AIDP. In this condition, there is autoimmune destruction of Schwann cells in the peripheral nervous system. It occurs often following an infection, and a high-yield example to keep in mind is Campylobacter jejuni. Because the PNS is affected, it causes ascending paralysis. And one of the first signs you'll see is absent deep tendon reflexes. Later, it causes respiratory failure, as the ascending paralysis involves the diaphragm, which is why these patients should be monitored closely and treated with respiratory support. Plasma exchange and IVIG can also be helpful. Next, let's discuss acute disseminated encephalomyelitis. This is an autoimmune demyelinating condition of the CNS. It occurs following vaccination or infection and presents with multifocal neurological symptoms such as motor deficits, as well as encephalopathy, commonly manifesting as altered mental status. All right, now let's discuss Charcot-Marie-Tooth disease. This is a group of genetic disorders resulting in a defect of myelin or peripheral nerve proteins. The most common type is Charcot-Marie-Tooth disease type 1A, or CMT1A, which is caused by a PMP22 gene duplication. It presents with sensory deficits, lower extremity weakness, and foot abnormalities such as pes cavus. Here's an image of pes cavus. Normally the arch of the foot should be much less prominent, and in this image we can see that the arch is quite high. Again, this is called pes cavus, which is a feature of Charcot-Marie-Tooth disease. Okay, now let's discuss central pontine myelinolysis. This is an iatrogenic disorder caused by the rapid correction of hyponatremia. Rapid elevation in sodium levels leads to excess water being pulled from neurons. This leads to demyelination that occurs in the pons, hence the name pontine demyelination. Here's an image of an MRI in a patient with central pontine myelinolysis. Notice how the pons is the area primarily affected, and we can see that quite well right here. Damage to the pons is what can cause locked-in syndrome. This causes pseudobulbar palsy, which is an inability to control facial muscles, along with quadriplegia. So basically, all the patient can do is blink. Everything else is paralyzed. All right, now let's finish up by discussing other disorders. Some other high-yield disorders to keep in mind are lysosomal storage diseases, such as Krabbe disease, adrenoleukodystrophy, and metachromatic leukodystrophy. We won't cover these here because they're discussed extensively in our biochemistry section as memory palaces. Another disorder to remember is subacute sclerosing panencephalitis. This is a demyelinating disorder that occurs as a complication following a measles infection. We discussed this in more detail in our microbiology video on measles. Finally, progressive multifocal leukoencephalopathy is a complication of a JC virus infection. It causes demyelination of oligodendrocytes and is a rapidly fatal condition. And again, we discussed this in more detail in our microbiology video on JC virus. All right, now that we've covered all the information, let's review with another question. A 22-year-old female with no past medical history is brought to the emergency department after collapsing at a marathon. The patient's current temperature is 38 degrees Celsius. Blood pressure is 110 over 80 millimeters of mercury. Heart rate is 95 beats per minute, and the respiratory rate is 19 breaths per minute. The patient appears lethargic and is arousable to pain. Her friend states that she was drinking a lot of water and sweating profusely during the race. While performing a physical exam, the patient begins to have a seizure. Serum sodium levels are 110. Which of the following is a likely consequence of the rapid overcorrection of this patient's electrolyte disturbance? A. Pontine demyelination. B. Increased ventricular pressure. C. Brain herniation. Or D. Cardiac arrhythmias. All right, the important thing to recognize here is that this patient is suffering from hyponatremia. The patient was running a marathon, drinking a lot of water, and sweating profusely. This caused her sodium levels to drop to dangerous levels, and rapid overcorrection of low sodium levels can lead to central pontine myelinolysis. This can lead to pontine demyelination and ultimately cause locked-in syndrome. So the correct answer is A, pontine demyelination. Again, this is due to the rapid correction of hyponatremia, and this rapid elevation in sodium levels leads to excess water being pulled from neurons, ultimately causing pontine demyelination. B is incorrect because increased ventricular pressure is not involved with central pontine myelinolysis. Rather, it's associated with normal pressure hydrocephalus. C is wrong because this is most common following trauma. Trauma to the brain can lead to hemorrhage, which can then compress the brain, resulting in herniation. D is incorrect because when cardiac arrhythmias are associated with electrolyte abnormalities, potassium disturbances are most common. And these are unlikely to cause a seizure, as this is more suggestive of a neurological abnormality. So D is incorrect. And again, the correct answer is A. And that concludes this section.